смотри.
Тринтин.
Тринтин шватер, да?
Да,
Все хорошо. Hello, dear colleagues, how are you? My name is Mynzhylky Berdikhojayev. My assistant, Rowan Maratlı Aytili, very famous Kazakh neurosurgeon. Rowan attended SLICE meeting, and I hope many colleagues can recognize Rowan. Yes, Rowan. Okay, this is a presidential national hospital in Almaty city, Kazakhstan country. And the case number 1 for today, young lady, 65 years old, came with the new aneurysm in the MCA territory. This patient was operated in 2014 at my time in National Neurosurgical Center in Astana. She had a supraclinoid ICA right side aneurysm, and at that time in 2014 we did a balloon occlusion test, everything was okay, and then we decided to coil the aneurysm and occlude the ICA. And I'm following this patient for more than 12 years. And now, this year, patient made a new MR, and this MCA aneurysm were found. And I think something here, we should do angiography for this. And also, this one is also new aneurysm. This is choroidal segment, and this should be the PCOM segment, but it's look like new aneurysm. And okay, we should check this one, 50-23 caudal, and this aneurysm is on the MCA 2 millimeter. It's a microaneurysm. It's something like this. Okay. 47-36 caudal. Okay. The ICA on the right side were occluded. Okay. Now we are in the femoral artery region. We should first reach the ICA. Okay, let's see the angiography. This is the aneurysm. This is the aneurysm. And might be the one more aneurysm on the ACOM, microaneurysm. Yes, this artery was occluded, the coiling of the petrocavernous segment, some coils inside the aneurysm, and the situation were stable. Yes, the ICA is filling from the ophthalmic, but the aneurysm is not growing and not filling. Vertebral-basilar system is normal. Some kink, it's okay. She's a young lady, 65 years old. Okay, and then this is aneurysm. 2 millimeter, 2.4, and something here. And also ACOM we should check. Yes. AP and lateral, maybe it's working projections. It's rotational. It's look like clear ACOM, but we should check once again. It's better if the ACOM territory is clear, yeah? It's better. This is choroidal artery. It's look like something like aneurysm. We measured for the case if we need to place something like stent. It should be 3.518 Leo plus. But the problem is aortic arch and the aorta, iliac arteries, the first angiography done from the femoral with the Klimber 8 French Judkins right, and Rawan could reach the only common carotid artery, this segment. Yes, it's a little bit problematic. Here the kink. Okay. Today we have a team. Madina is operating nurse. Nazım is a Akhil Tate is a second nurse, operating nurse, and new anesthesiology team. Anesthesiolog now. Okay, we can clarify the name of the team later. No, наш vessel. Okay. With the new team, we tried to do the introduction for the neuroanesthesiology, but all the time new team. Huh? It's all the time problematic. Okay. Yes, I just arrived from Tashkent. Yesterday in 4 hospitals in Tashkent we made 7 cases. It was the first hospital, Neomed Cardio. It's a cardiology hospital. They have 2 Azurin, Philips Azurin, 3 cath labs, and then at Neomed Cardio we have done together with the Bunyod Karimov and the medical company 3 cases, intracranial only vertebral artery critical stenosis after stroke. Patient were already stented for the ICA stenosis, and she had a one side hypoplasia of the vertebral artery with the critical intracranial stenosis, and the second side V4 segment critical stenosis. That's why we made a stenting for that patient. Okay, it's a little bit problematic. It's not rotating, it's a Judkins left coronary guiding catheter. That's why it's behaved like this. Okay, maybe we need to change the inner catheter. Правый коронарный шестерку вересанша. Мадина. Правый коронарный шестерку вересанша. Правый коронарный шестерку Бурма. Yes, after Neomed Cardio, we went to the Soglom Hayat Hospital. It's a new hospital. They had a Трое Кlimber. Klimber трое. Alt French Klimber. Yes, in Soglom Hayat Hospital, it's also multi-profile hospital. They installed new Chinese angio machine. The name is NewSoft. Monoplane machine, and we made vertebral artery V1 segment stenting. And after that we went to the Sinomed Hospital. It's also multi-profile private hospital in Tashkent. And after Sinomed. We made two patients in Sinomed. The one patient were, yes, in Neomed cardio it was 3 patients with stenosis, and one of them were with the of supraclinoid segment aneurysm. We placed the pipeline stent, and in Sinomed hospital we treated patients with the carotid stenosis, and yes, patients were with the intracranial stenosis, but intracranial stenosis were not so significant. That's why we stented only one carotid, and then the second patient were, I think, with intracranial stenosis, and then after 2 cases, okay. Now let's look at that. Yes, I like the Neuromax catheter. It's possible to send high enough. Shit, c'est ça? Oh, c'est ça. Non, c'est ça. Okay. I forgot one of the patients we treated in Sino. I think it was also the stenosis. Yes. Intracranial. And then the patient with the brain AVM arrived to the Shoch hospital. Shoch hospital is near the airport. It's also the private hospital. And we went to the Shoch hospital. It was not expected. And then we treated the brain AVM in left parietal lobe, nearly 3 centimeters. Less than 3 centimeters. One session, complete occlusion. And I should stay in Tashkent, and just arrived to Almaty in the morning. And also so many bad news. It was an earthquake yesterday in Colombia. And I hope all my friends and their families are safe. And our deepest condolences to the families who lost their relatives, and also to the colleagues. It's also very sad. Okay, it's a spasm. It's not good. Okay, now it's okay. It's only for carotid artery, that's why we don't need the spasm. Okay, now it's better. Okay. I think it will resolve, no problem. Yes. Okay. It's a treatment of the vasospasm. It's a classical algorithm. How to check the... I'm sorry. I'm so sorry. We didn't prepare the sonic. Yes. Yes, it might happen. It's better to recognize that it was happened at the carotid level. Okay. Opa! Yes, it's rupture. Okay, no problem. It was too much pressure inside. It's okay. It's a mistake, but it's okay. Eclipse aspiration. Eclipse. Yes, it was in saline, that's why. That's why it was ruptured. It's okay, it's a human factor. It might happen anywhere. It's better that it's happened outside of the patient. And it's not the fault of the manufacturer and balloon. It's just a malpreparation. Okay, it was one of the last septors. And now we're preparing the eclipse the same way. We took the balloon up. We should take out the air from the system. And now we need a Y connector. Yes, it's a human factor, it might happen everywhere. Even with the 18 years experience in endovascular, it also might happen. It's the instruments, it's physical devices. Okay. Now balloon is deflated. It was negative pressure and now it's zero pressure. Okay. Yes, first of all we should exclude the ACOM microaneurysm, and the projection is caudal 36. Ана гемодинамиканың құйрығын bir turtup жіберсеңізші. Caudal 36 and right 42, but patient is moved because of the general anesthesia. It's not the same projection. Okay. Okay. Right. 47. We will do it with the lateral plane and the caudal 36. No, not this one. This one. Okay, let's see the AT. You can check 3D roadmap. Let's take it out. No. Okay. 3D roadmap is not working, huh? It's not working. I don't know why. But 3D roadmap is not working. I see it first time. Yes, on lateral view we should see the microaneurysm. I'm not sure there is an aneurysm. It's just an irregularity, yeah? No aneurysm. Yes, there is no aneurysm. Okay. This aneurysm is there. I think we need a stent, huh? I think we need a stent. Okay. Okay, let's check in a classical way. Now you can see the balloon is inflating. It's properly prepared. It's very important. I think we can change the view. On this image it was better. AP and lateral. 80-14 колдал. AP was 0. Yes, AP important to go through the IC aneurysm. And the lateral plane was 14 caudal 80. Caudal 80 and 80 right. So it should be something like this. And all the time question if you work with the one balloon, which branch should be protected. I think the lower branch is okay, but upper branch is also okay. Okay, smart mask. Usually catheter is going to the MCA, but in this case it tries to go to the ECA territory, anterior cerebral artery. Okay. Okay, now we're in the lower branch. The balloon at the neck. We'll use yes, okay. We have a narrow max catheter, 6 French 90 centimeter, and navigated with the Klimber 6 French guiding Judkins right coronary with the 35 hydrophilic wire from Truma. Okay. And then we tried to use scepter, but scepter was not working. And after scepter yes, scepter is ruptured outside of the body, and then we opened the Eclipse double lumen, and now Eclipse double lumen 615 placed at the MCA bifurcation and neuromax in the IC. After all of these steps, now we are taking headway duo. We pre-shaped headway duo 45 degree, headway 17, yes, sorry, with 45 degree. Yes, it's a little bit more than 45. I will just a little bit straighten. Yes, and yesterday we had a patient with the brain AVM, and at the final stage it was leaking from the Y connector, and at the end of the procedure the thrombus was formed in the guiding catheter, and after that it was MCA occlusion with the thrombus, and we did the Sophia plus thrombus aspiration. Oh, it's something small. Okay, I think the angulation is too much. Huh? Что-то градус копирует. Прямой катетер дурский катетер ногу. Yes, so now I will try to rotate the headway, which is 17. I think we should go to the upper branch. Yes, and after that we can navigate it. Okay, just a second. It's all the time tries to go below because of the shipping, yeah? Shitty shipping. Or we should reshape the headway 17. It's all the time problem with this small aneurysms. Huh? It's touching the wall. Now it's shipping. Comes below the balloon. Balloon настанет как-то. Yes, we thought that the catheter will a little bit straighten, but headway 17 usually keeps the shape. If you form the 45, it will stay 45. That's the uniqueness of the headway. Okay, now we're inside the aneurysm. It's not one by one movement, that's why it's a problem. Yes. Now it's better. I will bring my balloon a little bit back. Спираль 2-2, бір жарымда 4 ашып бересің. Бери бер любой. Окей. Это удвоил. И бір жарымда 2-ні дайындап қоясыңыз. It's a complex 3D 1.5 by 4 Optima. It's a complex soft. Все, да, это. As patient is pre-medicated with the ticagrelor and tested. PRU is okay. It's very nice PRU. Okay, the aneurysm is 2 mm, but I asked to give the 1.5 by 4, a little bit undersized. It's better to undersize a little bit, and maybe one coil is enough, huh? Отделить. Yes, the question is, should we place one more coil or it's enough? For me it's look like enough. Okay. Let's take the coil, let's take the microcatheter out. It should be some place for the couple of another coils. I think we need to place a stent. Huh? Yes, I'm orienting on the IP. I think it's a little bit risky because the catheter is not as the coil is inside the catheter. It's a little bit problem. Okay, now we detached. Okay. Now we should be ready to stand. Which branch is better? Upper branch. Tuning сидишь. That's correct. Yes, we should deflate the balloon. Okay. A little bit up. Okay. It's not like it's okay without stent, huh? It's not like it's okay without stent. It's just a one coil, 1.5 by 4, and the aneurysm is fully filled. Okay. Okay. Let's leave it here. It looks like everything is okay, huh? And the question is, should we touch the ICA? Huh? Ровно. Или кере жоқ па? Yes, yes, I fully agree with Roman. Maybe we will just follow the IC aneurysmal segment. It's something here. Okay, this is Andrew. Так, aneurysm жабка. Yes, aneurysm is occluded, the MCA1. Okay. Let's check in this projection. Sola verin zaten. Yes, for me it's look like infundibulum because the contrast is at the top of the enlargement. The contrast is flushing with the flow from the PCA territory. You can see this one. You see? It should be thickum. Yes, the aneurysm is occluded. Now we can take out all instruments, and it's possible to do 3D CT control, and then we can finish the case. Чашка вырисашь? Sharp. It's so-called hijama. Okay. Yes, for today we planned 4 cases. I see big aneurysm, the next one, and then posterior fossa meningioma, and after the meningioma we have MCA aneurysm, one more, and for tomorrow 2-3 cases also. Now I will ask Roman to do CT. After CT, one more angiography, and then we can finish. Okay, let's wait for the CT. Dear colleagues, expert CT looks normal. The artifacts from the previous coils and the new coils in the MCA territory. And now Rawan is already done the APN lateral control. Little bit scary about the tail of the coil, but now angiography looks normal. We can finish the case. We will disconnect the ticagrelor and patient will be on aspirin for 1 month. And for the ICA infundibulum, we decided this is infundibulum, and for this one we will follow, and if it will not grow, just follow up. Thank you for watching. Next case is ICA aneurysm. See you in 30 minutes.